But yeah, so we want to have a conversation. Things in the medical world are changing. Education is not yet changing, especially in medical school. When I see people like Benjamin who are trying to redefine how we need to educate and unlearn, he as a person or everyone here interacts with the healthcare system. Yeah? The frustration of their lack of, they say doctors lack soft skills, industry skills. But do we learn this in medical school? So, Benjamin, just to start off with you, to do an intro, and what is your perspective about capacity building? You as a person who interacts with the healthcare system, what would you define it as, and how would you want to see it? What is its current state?
Thank you, Dr. Martin. I feel like those are about three questions addressed to a couple of things. For starters, my name is Benjamin Rukwenje, and I run an enterprise called Boundless Minds, whose work is to prepare young people for the world of work. And how we do that is work readiness training that focuses on soft skills such as critical thinking, problem solving, and stuff like that you won't find in your conventional classroom. So that should also tell you how we teach them. And two is mentor matching, so linking young people with professionals in the workspace so that it's easy for them to learn to transition into work because of that gap between school and industry. So that's essentially what we do. But just to get to what Dr. Balala is asking, at the risk of sounding irrelevant, my understanding of capacity building is to build capacity, right? And that it comes from the understanding that there's not enough ability to execute a given task, right? So what capacity building does is that it provides the tools, the resources, the knowledge, the networks for an individual or an organization to be able to execute the tasks as is expected, right? And without that ability, without those resources, tools, networks, and skills, if you like, that required task would not get executed in the way that it should. And so when I think about it from the health perspective, it's perhaps a good thing, maybe, to say that the health workers that I've interacted with, I would generally say, I feel, have their capacity built. In fact, in my uneducated guess, I would say that medical school is perhaps one of the few programs at university where you're likely to find a wholesome graduate in terms of their academic and technical ability, but also in terms of the wholesomeness of a person, in terms of all of these other skills. And you see it in how diverse the interests and knowledge and abilities of doctors are and go beyond their given practice, right? If you compare medical students, for example, and I say this because I work with students, so if you compare medical students, for example, against other graduates, you will find that many of the things, so ability to speak, ability to do research, ability to write, to network, to manage people, all of those soft skills, you'll find that they are generally lacking in your average student when compared to medical school. So that's for me, when I interact with health, it's something that I notice. especially with health workers. It's different from when you interact with the health system. The interaction between technology and not just health, but with education, right? So for us to be able to think of that interaction, we must also go back and examine how we got here, right? Yeah. Because your average health worker is not prepared or doesn't even work and function outside of the system in which the rest of us exist. They go to the same schools as we do. They interact with the same economy and the things that work or don't work in the same way that we do. So their ability to succeed or not is also built around the same abilities or inabilities that we interact with. But if you approach it from that aspect, you realize that if you think about education in the way that we learn, right? Many of us here, I think if you poll this room, you'll find that maybe there's 30 people, which represents about 30 different schools, right? Or maybe 50 if you add high schools and university and stuff. And all of us went, to different schools, but somehow the things that differentiate us are not that many, right? In terms of how we are shaped as professionals. And the reason is because we are all educated in the same way, right? All of us, maybe not all, but many people in this room will remember having been in a classroom where the teacher stood in front, right?
Right.
Where the teacher is the one who knew what they were teaching and you didn't, right? You just came in with what was assumed to be an empty head that was going to be filled. You did an exam that tested you for what you remembered, not what you understood or what you could create, right?
Right.
And the mode and language of instruction wasn't your local language, right? So if you think about it like that, so that's how education, formal education as we know it, is curated. But that education that we all went through, that we all go through, was designed to produce a clerk, right? Clerical staff. Because clerical staff is required to memorize things exactly as they are given and execute them in the exact way that they were told. That's why we study the way we study. Now, if you think about the challenges that we face today, it tells you how divorced how we learn is from the things that we interact with. And I thought that this was important because when we talk about our interaction with health and technology, we must also think about how is your average health personnel trained, right? But also how is the person that's interacting with them trained, right? And when we think about technology, right, how are the users oriented in the way that this technology is supposed to be consumed or how it's able to deliver? Because I just explained to you how we learn. You spend, many of you here have probably spent longer in school than more than half the time you are alive in school, right? So that's how you interact with them learning, right? And if you apply that context to how then we interact with health and technology, you realize that a lot of the challenges, but also our inability to very quickly address them and adapt to the power of technology in which I am able to order for drugs and get them at home or get diagnosed, or in which I am able to make sure that my grandmother can very quickly locate or book an appointment and doesn't have to sit at the doctor's, even if she's going to a referral hospital in Fort Portal. So if you think about those things, right, the things that would make our interaction with health simpler, and how we study, right? You realize that this gap, the way we study is wrong, so how we interact with technology will also have challenges. So what I would tell the doctors and the ladies on the panel is, don't be so hard on yourselves, because it's just the way that the system is designed.
Carol, you speak from the heart about digital, capacity building for healthcare workers. How are you preparing healthcare workers to unlearn and learn and be malleable to what Benjamin is alluding to? Because the system trains us in a certain way. In the room I also have my lecturer, Dr. Noella, and how we, as a lecturer, as a teacher, how do we undo these things to make our doctors and healthcare workers ready for the new landscape of healthcare service provision?
Thanks, Martin. Good afternoon, everyone. My name is Carol Kamasaka, currently working with JSI as a digital health advisor, and also the president of the Uganda Health Informatics Association. And I'm really happy to be here and to speak about capacity building for the health workforce. One of our objectives as an association is actually to advocate for in-service training and capacity building for the health workforce in not just digital health skills, but ICT skills. I've formerly working with the Ministry of Health, and for me, I experienced these challenges firsthand. I don't know, maybe we've been doing it wrongly and pushing for digital health tools, implementation of digital health tools, and we have actually come to the point of implementing patient-centered digital health tools. The users of these tools actually are the health workers, and when we look at the education system and when they went to school, which is about 20 years or maybe more years ago, the computers were not yet introduced. And I was at a conference last week where the nurse spoke about her first day at work. She entered the hospital and there was no computer, and she was worried about where she's going to get information from. Right now, we are in the era where there are computers, but our health workers can actually not use these computers. The capacity is not lacking in actually using the digital tools. The capacity that they lack is using the hardware on which these tools sit. You have a midwife who cannot even switch on a computer. You're seated at the national level and you're thinking, why are these people not using computers? And you call, no, you're not using the system, which is not using computers. And you interact with them, and okay, someone will tell you, maybe ignorantly, like, you know what? There's even no internet on this computer. But actually, someone was maybe going through the room and they kicked the network cable out. They don't even know that, oh, there's actually a network cable. There's a network port. And they don't even know how to troubleshoot the small issues, and they have to keep reaching out to maybe the center, to the district. There's no internet, the computer is off. Maybe the battery died, but they don't even know that the battery died. They don't even know where to check if the battery is dying down. So, for me, I think it is time for us, the implementers and the government, to rethink our way of implementing these solutions, because at the end of the day, it is the health workers that are going to use these tools. It is the health workers that are actually going to do the last mile implementation of the digital solutions. So we go back, and while we are designing these tools, also we need to keep at the back of our mind our users who are the health workers. We design with them, but the focus should be on training them in the basic ICT skills. I mean, if a health worker can use a computer, AI is not going to be difficult. It's not. They'll be able to interact with their counterparts within the room. I mean, you don't have to first write a letter, write a memo. You can send an email, but you don't even know how to send an email. And the Ministry of Health actually did a capacity needs assessment, I think about a year ago, and the findings were actually disturbing. For me, them being at that level, they were disturbing. That's when I think we were doing it wrong. Find that about 50% actually cannot use the computer. 50% of the health workforce is big. So the problem is not the gap in using the digital tools, but the problem is the gap that is in the inability for these health workers to use the computers, to use the tablets. We are going to community health workers and giving them tablets to implement and to use digital tools to deliver service. But they have never owned a smartphone, they have never owned a tablet, they don't even know how it looks like. Then you give it to them and you're training them how to use that tool. And let's say it's just an application, you're training them and you're sitting them in a classroom setting. And you see, this is the application, looks like this, you download it from Google Play, Play Store, and all those stores, and this is how you log in. They don't even have it in their hands to actually practice. And then we expect them to go back and voila, tool, start working. No, I think we need to go back and train from the first principles. This is a tablet, this is its power button, and actually, they get excited because the ministry did a pilot training, and they designed a program called Building Health Informatics Capacity for the Health Workers, the HIC program, supported by the partners. And the feedback, for me personally, I got feedback on mail, the calls. They were excited to learn how to use computers. And they knew that now they had arrived in the digital era. Because for them, that was the only gap that they had, the lack of ability to use the computers. So I think we need to go back to the first principles and train health workers on actually how to use the hardware, how to do the small troubleshooting around before you call for remote support. Thank you.
Thank you so much. So two things, education, we need to rethink education. Then how do we do effective skilling and reskilling? And this is a space that Benjamin also is, and most of his submission was about. Linda, what's different for you, or what is similar? What is your experience with, the capacity of healthcare workers to utilize the systems and the tablets that you give them to, run some of your programs? And how different are you doing it? What has been your experience?
Okay, thank you so much, Dr. Martin. Well, with regard to understanding how health workers utilize these digital tools, you'll find that the experience is not any different in most places, even in urban areas where we think, no, this is Kampala, this is a modern hospital. It's not possible that a nurse doesn't know how to use a software system. So I think everything goes back to how a system or an application is launched to the medical workers. And maybe we could look at benchmarking successful applications that were launched in the market, like Safe Border, where you have a population that people would think is quite illiterate, but actually they know how to operate the Safe Border app. So maybe understanding how did Safe Border get a community of illiterate people to utilize an application and make it successful. What kind of capacity building did this team of people go through? Therefore, can we then benchmark what was done when we are launching certain healthcare systems or programs? And maybe we shouldn't take it for granted that people will learn on their own, because technology alone is a new space for everyone, much as, of course, those who are being exposed can easily learn on their own. But it also goes back to the kind of education background that a person had. There are different types of learning techniques. Montessori, for example, talks about exposing the child to the actual experience of maybe the product versus formal teaching. So you find that with that kind of learning, a child is inquisitive, so they get a creative mind. Whereas someone who has been in a system where it is, I lecture, you read, you cram, you find that they're still seated waiting for you to teach them how to use a product. So for all systems, my understanding is not taking it for granted in terms of how we launch these programs to the health workers, but also looking at applications like Safe Border, Jumia, and how they've been successful on market. I believe it gives us a light at the end of the tunnel that not all hope is lost. It's possible for people to adapt. I mean, all of us were forced to adapt during COVID. We had to look for ways to survive. So if we look at technology as an enabling tool, then we could all get ahead of the game, knowing that we must learn this before robots replace our work. Therefore, what can we do to be ahead of the game?
Thank you so much. Very interesting, because the last bit will be very interesting because I know Benjamin and the rest of you have been doing quite a lot of things. But Dr. Carol, what's your experience with the systems that that your company is developing? How do you find their absorption and interaction? What's the feedback? What's people's perceptions?
Thank you so much, Dr. Balaba, and thank you so much to my colleagues. I'm just learning. Let me throw a spanner to the works, Dr. Balaba. I think I'm the youngest person in my company. Not one of the oldest, people in my company. We have so many young people who are working with us, and we've learned a lot of things in regards to what we are doing. So what am I doing? I am the country lead of a company called Baobab Circle, and at Baobab Circle, we build mobile technology solutions that are able to sort out the biggest problems of affordability and accessibility of healthcare. Our flagship product is AfyaPack, which is available on Google Play Store. You can download it right now, and you can be able to use it. We want to, first of all, solve the complex problem of non-communicable diseases, especially diabetes and hypertension. And so how we do that is by utilizing artificial intelligence to be able to coach somebody on a daily basis, how to eat, how to exercise, how to remain positive on their journey to great health, whether you want to prevent or whether you want to manage the disease. The second thing we do, we offer you access to our doctors, and also doctors in various health systems, for example, hospitals and clinics. And the last thing we do is remote monitoring, still on the same platform. So you can imagine the complexity of the platform. So you ask a question. How then are we able to deliver that kind of a solution that is so complex, but just very user-friendly and using the digital workforce? So first of all, I'll say we have to define who the digital workforce is in every organization. My colleagues talked about nurses. For me, I have the software engineers behind the scenes, the data scientists behind the scenes. I have community health workers who deal with the households, especially in vulnerable communities. We do a lot of projects with different stakeholders. We have me, who is a healthcare provider who has also gone through my whole transition. Dr. Balaba, you talked about when we went to medical school, there was no YouTube. So I've also had to go through my own transformation of having to learn all these technologies. So today I can throw around some acronyms that very many techie people terrorize us with. Have you ever seen tech people in a sentence, the whole entire sentence, they're talking about acronyms and you're wondering what are they talking about? So nowadays I can be able to throw around some acronyms because of the transformation that I have gone through as a pharmacist, right? Now, the first thing that I have learned in my company, Baobab Circle, the thing that has worked for us is to identify who the digital workforce is, because you cannot copy and paste in terms of that training. You will, as I said, you have me, Right now, I'm in charge of strategy, business development, partnerships. I lead the country operations in Baobab Circle. Obviously, when I went to medical school, did they teach me that? Absolutely not. I'm actually currently going through my MBA to be able to effectively lead organizations. I have had to go through my continuous learning process. Now, you have the doctors who are working with us. And as my colleague cited, when we went to medical school, we were taught diagnose and treat. So you have a stethoscope, you diagnose and you treat. Now, I have a telemedicine platform. My doctors never see the patients. They cannot touch the patient. So how are they able to make an effective diagnosis and be able to treat that particular person? So the training for doctors is actually totally different. Then you go to the software engineers and technology wizards behind the scenes who talk in acronyms. For those particular people, their biggest content gap is understanding healthcare. Now, I was just telling a colleague over lunch, and I said, you techie people, you build softwares for yourselves. You know why? Because a techie person is a very impressionable person. They sleep today, they wake up tomorrow with a new idea. Every day they are walking around with new ideas. So many times when they produce something, a prototype of something, it's so fancy to them and you can hear the emotions of when they're presenting to you, but then you keep on wondering, who's going to use this product? Because it's too complicated for the normal person. So we have to come back and feedback to them and say, this is an amazing product, but walk me through the user journey. This UX is not viable for this vulnerable person in a grassroots area who's unable to even, as my colleague said, has never even held a mobile phone in their lives, and what they have is a basic phone that actually does not have all the functionalities. So the first thing that we need to do is to do what? Identify who the digital workforce is in our different organizations, because we're very different. I'm in the health technology space, we build technology, so we'll talk technology all the time. If you're in a hospital, define who that person is. The second thing is, I've talked about identifying the content gap, which is very specific to every cadre, every discipline in that digital workforce. The third thing I'll say is a timing gap. I always say you cannot teach an old dog new tricks. So for what has worked for us is that it's a culture in our organization to learn from the beginning. What we do, how we do it, and why we do it. And let me start from the end, why we do it. The reason why many people are so resistant against change, because people are resistant against change. I think things like COVID just got us out of a comfort zone, and now we are doing different things. If you had brought that kind of technology without COVID, I promise you the adoption would be very low. I don't know whether you've started. I know we were there since 2016 trying to talk to people about digital health, digital transformation, and people are like, how? I need to go to hospital for somebody to actually be able to treat me. So, change is difficult for everybody. So how do you ensure that there's continuous change within the organization? They start from the beginning. Because if you start at the end, there's a problem. And you have to emphasize the why behind the what. I like what Simon Sinek, one of my favorite speakers and authors, says that you have to start with the why behind the what and the how. If what we don't do is sell the vision for these things, we bring new technology, we bombard people, we bombard nurses, we bombard everybody, and everybody keeps on wondering, where are we going with all this hullabaloo? The first thing you have to build the why behind the what, sell the vision of why this is important to us. For us, we have a big, hairy, audacious goal of solving affordability and accessibility of healthcare in Africa. That's the mission that everybody from top down really understands. And that is echoed from day one. From day one, everybody understands the burden of disease, of non-communicable diseases. People will echo the statistics like it's on their fingertips. 1 in 4 Ugandans have hypertension. Average age of people who have diabetes in Uganda is 35 years old. This is why we are doing this. The mobile phone penetration is this, and therefore, Baobab Circle comes to solve 1, 2, 3. Very important to sell the vision of why you're doing this. Then get to the what of the matter. And the what of the matter is what I've just talked about in terms of content. And to build, the last thing I will say is fix the trust thing. There's a trust gap between technologies and the people who use the technology. And I'll tell you, there's also a trust gap with the patients who this technology is supposed to do what? To be able to help. And so this is how we've been able to mitigate it at Baobab Circle. The community health educators are the last mile of patient education between the software that we have and the person. When we started, I promise you, as I told you, we are technology, we built things for ourselves. We went to social media and we invested a lot of money for promotions. I don't know how many people do a lot of marketing here. And we did that. And guess what? The adoption was very low. Because despite the fact that we are still in a digital era, people want to feel and see somebody behind the technology. So we started the Community Health Educator Project to mitigate that behind every technology, there has to be a human being presenting the technology. It was very interesting and a very unlearning for us, and I think the first speaker talked about learning and relearning. And what we learned is that there's a way when somebody goes to somebody's house, sits down with them, speaks in Luganda, and really explains this technology to somebody. Now somebody says, wow, I'm able to understand. So that has been our learning. The trust gap has to be mitigated. It has to be mitigated with the vision why you're doing it, but also most importantly, for every technology, put a face behind it. People still want to see and feel who this person is. Abstract things don't work, at least in Uganda, at least for now. Thank you.
Thank you so much. And it's interesting to hear some of these real-life examples. The most uncomfortable, and I think all of you will agree with me, leadership and policy. What's the role in redefining education, reskilling? What has been your experience? Because for us to build these resilient systems, you always need leadership. So lastly, and briefly, we started with Carol, who decided to run away from the ministry. I don't know why she ran away, but now this question is coming back to you. What has leadership and public policy have to do with enabling, the digital transformation by reskilling and redefining education? We've had new curriculum, for primary, secondary, but are people employable, soft skills, digital skills? What's the role of leadership? What was your role as a leader at the ministry at the time you were there? Sorry for putting you on the spot. But yeah, we need to be honest and say, this is my experience, this is what's lacking, and this is what I propose we need to do.
Thank you. So the thing is, we are here, we're already here. How we got here, I don't know, but technology happened to us, and we are not going to run out from it. It's like a city that has been built without a plan, and now you get new leaders and they have to put a plan in place. So the role of government is, and I know in the national plan there's a lot of digital transformation that is mentioned, and we need to look at an all-inclusive digital transformation. Education, health, ICT, and the rest. So while building policies and developing all these strategies, we need to go back to the users of our digital transformation tools. I know we are not going to tell our nurses that, if you can't use a computer, you go back home. So we need now to work on policies that are going to support them to change their minds, like she mentioned, but also to support them to use these tools, develop curriculums that can help them support these tools and train them. I know there's one that has been developed for basic, intermediate, and advanced skills in ICT and health informatics. And these trainings can be in service. These health workers go for training, so this can be part of the trainings embedded within, and you bring it in, and slowly by slowly, I know that they're going to pick up. But also going back to the pre-training, the government can work on reviewing these curriculums. They're not casting stone, they can be reviewed, and these trainings be done from the lower levels. They don't have to wait to go to medical school to learn how to use computers. They can learn how to use computers from even the primary level. So it's all doable. I don't think we are living in a static world. These policies can always be amended and changed and revised. These strategies are revised every after five years, I think, even the plan. So these curriculums can be brought on board, the trainings can be brought on board. And we have a lot of these bodies, this organization, we have the Health Informatics Association and other bodies that can support this training. We have, I think there's a training school for health workers. Is it in Soroti?
As a medical school?
No, there's in-service training, yeah, for health workers. The one in Ibali, yes. Yeah. These trainings can be embedded within those trainings that happen in service. Yeah, thank you.
Thank you so much. Linda, briefly, and then go to Dr. Stella, and then you will close off, and then we shall have 2 questions from the audience.
Thank you so much. I just want to pick up from learning from what Dr. Stella was saying earlier. When it comes to human-centered design, I think even as we develop curricula that is going to build capacity of the health workers, we also need to understand first, how do these people learn best? So going back in terms of how the curricula is being developed, adult learning is different from training someone who's still in school versus someone who has 5 kids, has a marriage, has work. Their concentration levels are totally different. So how enabling is the curricula that would come out that's aimed at building capacity in the digital space? But then as well, we also need to revise our policies that we have in place and probably amend certain acts. I'll give an example of the National Drug Authority and Policy Act. As a pharmacist, it doesn't allow for automated dispensing, and yet we're now in the era of automation. So it means that if such laws are still in place, then it means the environment is not favorable for automation to take place. So for development of capacity, we would look at policy and also the kind of curricula we develop and how it's developed.
For me, I think we cannot talk about technology if we don't talk about the infrastructure. We still live in a world whereby, yes, we're going to provide the technology, but then at the end of the day, how are these people learning? And as Carol mentioned and Linda mentioned, that you have to build it for them, with them, all right? The government has to find a way, even in terms of curricula. It's not just putting things on paper. There's a difference between policy and practice. And I believe we've made very many milestones. If you think about the National E-Health Policy and Strategy 2018, there's definitely something there about workforce development. So infrastructure is very important. How are people learning? Then think about the barriers to how people really learn. And I'll quote something that I've often said. Imagine I rely on data to be able to log into a platform to learn, all right? And data is the most expensive in our part of the world. I think it's very important for us to have that conversation. That where are these people learning? We can't learn on a book. You cannot learn how to ride a bicycle by reading a book. You have to be on the bicycle and ride the bicycle, fall down and learn, and then, you perfect the art of riding a bicycle. The same way, if you're going to perfect technology, you have to learn with the technology. But the technology comes with other things. Can we subsidize, get concessions for things like internet, data, for healthcare? Call to action, right? Now, the second thing I'd want to say is this. I think one of the things that Silicon Valley has done so well is we use case studies to be able to learn. Now, if you come in isolation and teach somebody technology, for example, if I came and I did a full session of how to code, and that code lies in a vacuum and they don't see how that code solves a healthcare problem, then the truth of the matter is I can continue doing what I have always been doing, because anyway, when I went to medical school, I was taught this is how I treat malaria. So if we do not have enough data or use cases, case studies to show how technology has been able to solve the malaria problem and infuse it in the curriculum, then we have a problem, because the person doesn't actually see all this wahala halabaloo that I'm learning here. How is it going to actually make a difference in reducing the burden of disease in this particular disease? So I would say, let us collect data. We have a lot of data. The problem is that we're not using data. So let's have enough use cases that we can be able to infuse in our curriculum. I loved when we went to medical school. I think Dr. Sabrina Chitaka was talking about problem-based learning. It really evoked how we, critical thinking and how we question certain things in regards to how we learn. And I think lastly for me, I would say, let us go back to the beginning and realize that we are living in the era of digital natives. My nephew today can unlock my password on my phone. So clearly, when they come to medical school, they are clearly not like me when I went to medical school many years ago. They are a different breed of a generation. So why start at the end to teach this person about technology? Why not start from the beginning, even with biology, at the end of the day? I would want people to start thinking about technology even before they come to medical school, because it's our reality today. We are digital natives. People have been born, I can see many of them right now here in front of me, digital natives. I think we are the oldest here on the panel, as I think the whole entire time we've been told the panelists are very old. But here we have digital natives. So clearly they are a different breed of a generation than us. So why not start from beginning, when they are learning biology, chemistry, math, physics, to come to medical school, infuse that curriculum with technology. By the time you're coming to medical school, you are enhanced. We do not have to think about how to train you again. So that's what I would add to that conversation. Thank you.
Thank you so much. It's good that these are very viable and palpable, ideas. Brendan, briefly, what do you have to say about policy leadership and us moving forward?
I like that, Linda talked about human-centered design, because that's something that I'd noted from the conversation that was ongoing. But one of the things that baffles me about education reform, both in this country but on the continent, is that we don't teach human-centered design as part of curriculum. Because first of all, it's the simplest thing to teach. You don't need any more money than you're already spending, so you don't need special budgets, right? And yet, the benefits of teaching human-centered design, right, are innumerable. So that's something that I would put a lot of emphasis on. I mean, we were talking about health, but for the benefits across the board, that human-centered design, that learning human-centered design can do, both for students and for practitioners and stuff like that. They are immense. But you also mentioned safe border. The thing that many people either don't know or forget is that Safe Border, Ricky, one of the co-founders of Safe Border, was actually a border rider, right? I don't know if you know that. Ricky, so Safe Border, I think, has 3 co-founders now, but the original Safe Border app, right? Or what Safe Border was before it turned into an app, it was started by a border guy, the Ugandan guy, because there are 2 Mzungu Safe Border co-founders now, but the Ugandan guy is a former border rider. And that's what simple human-centered design does, because he knew the mind of a safe border rider, or rather a border rider, so he could design an experience, or he could give its lived experience, essentially, right? And I think that's, for me, one of, so in talking about this human-centered design aspect, it's also another thing when we talk about policy and leadership, right? In my other word, I write a column, so in Daily Monitor. So some of the things I keep talking about is, you see, when you think about the brokenness in health systems, so people complaining about lack of drugs and all of this stuff, and no doctors and stuff like that, part of that is because the people in charge of policy don't interact with the health system in the way that you and I do, right? When they need to take a COVID test, they will summon a doctor to their home, right, or office. They don't have to go and line up. Same as when they need to do a test, when if they can't secure a bed in Mulago through a phone call, they'll fly out of the country and stuff like that. So we don't interact with the health system in the same way, right? It's the same thing with technology. The guys designing it, the guys funding it, don't interact with it. They never need it. The people they are designing it for, the ones that live with it and eventually dump it, are not the ones who designed it. So as long as we don't have leadership that, one, has an appreciation of technology, but 2, that uses that technology. The reason why I can tell, I don't own Twitter, but the reason why I can tell that Twitter has a problem is because I'm always there, I use it, so I can tell if there's a problem with the platform, right? And you need leaders. Many of us have Facebook accounts and Instagram accounts. You can tell when there's a problem with any of those accounts. If only our leaders and people in charge of policy and implementation interacted with these platforms, right? We would have, it would be easy for them to work in the way that they should work. But the platforms, we design, first of all, we design them from here in Kampala and then take them to Namtumba to get tested. You go to this health center, you probably take a computer or phone that they are going to use. So that should also tell you that they will not afford to use the phone if you take it away. So all of those challenges, it's because who are we designing for? Who are we creating for, right? And lastly, on this is the fact that I think that there's just so much duplication in terms of innovation. There seems to be something for everything, right? And I don't even know how people at the ministry keep track of this, because it seems there's a system for every single thing. There's an information management system for this, depending on the funder, right? And it's as an outsider, as an outsider, it's so confusing, but it also tells you, because you cannot be efficient if you're running multiple systems, right? Because what are you keeping track of? And why I'm saying marry? I mean, just again, let's leave here. Let's come outside here, right? So when you look at your information and data, right? So the same information that NIRA asks of me is the same that I give to UNED, it's the same that I give for a national, for a permit, it's the same that I give at the bank, right? Yet, if isn't there a way to marry that system so that we are able to get, so that's how I think, and if these things are complex, even for people at the start, at the top, right, who supposedly have gotten good education, are exposed, have traveled and seen how things work elsewhere, how much harder do you think they are for nurses and patients who never interact with technology